Okay, so I am Jen Nelson. I'm the new HA in Burleson. So what I'm going to present to both of you on, so I've got Summer behind the camera, and I've got Robin, who is one of the staff here as well. So this was a class for my master's that I'm getting in nursing leadership. Had to develop a process improvement, something like that for the facility that I worked in. So at my previous job, I had started this project, and so I'm at the final stage of having to present it. And so since I'm not there, I'm going to just present to you guys. So this project came about through a couple of events that we had had in my emergency department where there was a delay in care for obstetric patients. One of them was a lady who was diagnosed with choreo, was admitted to the ICU, and was never consulted with OB, and ended up being transferred to another facility when her OB was actually at our facility. So that was just one of the incidences that kind of led to, okay, we need to have something that rapidly identifies these patients and gets the appropriate multidisciplinary team to the bedside. So partnered with the OB director, who was a great mentor. He had been in the business for a really long time, great leader. I had used an OB rapid response at a previous facility, so had he. So that kind of started the conversation, and then this project came about as a result. So what is the alert? Basically, what the staff has been educated to at the facility is that we should be calling an OB alert for any perinatal patient that is critically ill or rapidly deteriorating. And this is somebody who's going to require management by an extensive multidisciplinary team, or they're going to need rapid surgical intervention, which is one of the examples that I'll provide in the information here. So perinatal patient is defined as someone who is antepartum, meaning that they're pregnant, intrapartum, the woman who's laboring or actively delivering, or postpartum, which is what most ER nurses forget, that period goes up to 6 weeks after delivery. So when would we call an OB rapid response? Now this is just examples. We have strongly stressed to the staff that this is not necessarily an all-inclusive list, that your judgment and the physician judgment should also be used. But an obstetric hemorrhage would be a reason. Actively seizing, sometimes, as ER nurses, it's not necessarily when a seizing patient comes in that you think of something like the hypertension that goes along with pregnancy. So altered mental status, ectopic pregnancy, with rapid deterioration, usually as seen in like vital signs, they start becoming shocky from bleeding. So we had to include that part in there because not all ectopics are unstable. Traumatic injury that results in a level 1 or level 2 trauma team activation. In our facility, level 1 trauma activations are pretty much the American College of Surgeons standard activations, such as penetration to the head, neck, chest, abdomen. Vital signs, our vital sign parameters fall in line with pretty much with what the trauma level activations fall in line with. And then level 2 traumas are more mechanism related, death in the compartment, long bone fractures, that sort of thing. Any kind of precipitous delivery outside the OB department, that's the one that has ER nurses going, holy cow, yes, call them, get them down here immediately. We did have a delivery in the toilet of our brand new ER. We had been open about 2 weeks. I had, through the construction process, stressed to the construction people, no, we cannot have auto flush toilets in the ER. These are the reasons why, because women deliver babies in the toilets down here. Infection control was all up in arms about not having auto flush toilets, but we got it approved, and then 2 weeks later we had a lady deliver a baby in the toilet, so that was a big win for me. So, or the perinatal patient who just has deteriorating vital signs in general. What do we define as deteriorating vital signs? A heart rate over 110, a blood pressure less than 85/45, a MAP less than 70, O2 sats less than 95%, or any suspicion of choreo, which that doesn't fall in line with vital signs, but suspicion of choreo. Now we did not include hypertensive blood pressure readings or MAPs on here because basically the rule for preeclampsia is greater than 20-point rise above their baseline. So that's going to be varying for every person. So who are our team members that will respond to this? Obviously, it's going to be the ED RN, who's going to be one of the primaries. they're going to be activating their response. This is just like with all of our other STEMI response, stroke response, trauma response, this is a nurse-driven response. Doesn't have to be run past a physician and have their blessing first, because we don't want to waste time going through that process. We want to initiate that team, and we'd rather call them off and say they're not needed than have wasted time. So they're going to activate that. They're going to be responsible for establishing at least one large bore IV access, preferably two. They're going to get the emergency OB cart, which was something as part of this project that we kind of tweaked a little bit. We had an emergency OB cart already, but we added a few things to it as a result of this process that we found would be helpful. They're going to administer any meds that are needed, get O2 started as needed. And then as team members start to arrive, they're going to provide that SBAR report to the team. And then they'll be responsible for handoff reports and getting the patient transferred to another unit or another facility, whichever may be needed. The labor and delivery charge nurse is going to respond. They're going to receive that SBAR. They're going to assume the primary role if needed. If this just turns into the laboring patient because she's crowning and she's fixing to deliver, she may go ahead and take over that primary nurse responsibility. And then she'll be responsible for helping to collaborate the transfer to labor and delivery or ICU if needed. Our NICU charge nurse is also going to respond. They're also going to be receiving an SBAR. They'll receive the fetal specific information if it's available. They're going to make sure that neonatal equipment is available. We do have a panda warmer in the department that has emergency resuscitation equipment, ET tubes, umbilical lines, all of that. So they'd be responsible for making sure that that is available at the bedside. They'll assist our neonatal nurse practitioner with the resuscitation process if needed, and then they'll be coordinating the transfer of getting the baby up to the NICU. Our health supervisor, just as with our other responses, they also come to this alert. They will be responsible for helping to coordinate the transfer, making sure beds are available. They're going to go ahead and get that SBAR report as needed. And they're just going to serve as a runner and assist the team as needed. Sometimes they fall into a default role of helping to document. Depends on who's on and if they carry a strong point in that particular alert, if they're going to do hands-on patient care. So, but primarily they'll just assist as needed. Our chaplains also respond. At this hospital, they had a fantastic chaplain residency, so we have them available to us 24 hours a day. They're going to provide the spiritual and emotional support to the family. If there happens to not be any family there, they're going to be responsible for contacting that next of kin as well. Then they're going to, after every code and most alerts, sometimes it's just quick and everybody, hey, we're fine, but they do lead a debrief process for the staff and physicians, and so they'll lead that. One of the things that was a change to our current alert processes, our pharmacists responded to some alerts, but not all. At this particular facility, we had rapid response on the inpatient side, but this would be something new for the ED, and the pharmacist didn't traditionally respond. So we found in the literature that a lot of the OB response teams had a pharmacist included because the medications are so different from what as ER nurses we're used to giving. You tell me to give a Pitocin drip and I'm like, oh, what? I don't even know what to start that at. So they're going to be there and available to help with that, and then of course resuscitation medications if it's needed, and then they're going to be there to help with calculations and draw up medications, especially if they're needed for the neonate, because that's another high anxiety point for the staff. An OB physician will respond as well. They will receive the SBAR. They will complete their OB assessment of the patient, and they will direct the team in care issues related to the OB patient. And then they'll collaborate with the ER physician or the trauma physician as needed. And then if an emergency delivery is imminent, they will facilitate the delivery of the baby. The ED physician will receive the SBAR. They're responsible for maintaining airway and getting that established. And then they're going to direct the care for the non-OB issues. And then they'll collaborate with the OB physician and trauma physician for care on an as-needed basis from there, depending on the patient's issues. The neonatal nurse practitioner will respond as well. They will receive the SBAR. They will give the newborn assessment, and then they will lead the resuscitation with the NICU RN, and then they will also be responsible for establishing IV access on the neonate, be it an umbilical line, that sort of thing. So for this project, I had to have 3 objectives, and one of my first objectives was to basically the development of the process. So establish an evidence-based protocol for activation of a multidisciplinary team that can provide specialized, expedited care to the bedside of a high-risk patient. So some things that happened to achieve this objective: there was numerous interdisciplinary meetings with our providers to get their input and their approval to move forward. Various department leaders were involved, and then this was also presented to the executive team for approval as well. Literature review was done to identify best practices throughout the country to incorporate into the framework, and then that was shared with the various team members. Probably one of the best pieces of information that we found, or best articles we found, was related to the development of a team at Vanderbilt University, which was a much bigger facility that saw a lot more deliveries than us, but there was a lot of pearls and best practices that we were able to take away from theirs. And then we utilized lean processes and the A3 process for a comprehensive approach to bridge potential gaps. So basically, by working through those processes, we were to identify things that just hadn't occurred to us and was like, oh, we should do that. So second objective was to increase knowledge of the staff in order to facilitate early recognition of the decompensation in the obstetric patient population while in the ED and LD labor and delivery settings through presentations to be at unit meetings. So basically, to meet this objective, I did do Skype meetings with the staff because I had already left my job at that point, but the ED manager and the OB director had me Skype in and do basically a very similar PowerPoint presentation to present this to the staff. Prior to my departure, project update and final information was presented to OB and ED managers so that they could move the project forward and go ahead and get the process implemented. And then at the time of the Skype meeting, there was basically Q&A with the staff, and so we talked about, different questions that they had. ED nurses are great for coming up with, well, if this happens, do we still do this? And so we walked through a lot of that. There was a lot of positive feedback and excitement for the project because, as most ED nurses, OB is probably the one area we're most uncomfortable with. So very much excited about the project, and OB is always excited to come down to the ED because that's some excitement in their day as well. So my final objective was to establish quality metrics related to the care of the ED obstetric patient in order to measure the effectiveness of a team approach to care. So basically, to meet this objective, there was an extensive chart review done to establish baseline data. So basically, we looked at door to consult, we looked at a variety of metrics, and was able to establish that baseline. And then what we'll be able to do is go back and reevaluate those same metrics at 3 and 6 month marks. There was a tracking form that was established, so any patient that met the criteria, first off, was the activation called, and then what was those specific things that we measured in the pre-information, what were our timeframes for those. And then, overall, by collecting this quality data, we wanted to make sure that we were providing timely, effective, efficient, patient-centered care. I had to identify a nursing theory for this, and so Orlando's nursing process discipline theory was the one that's selected. Basically, what she identified in her theory is that a patient's presenting symptoms are often clues to the cause of the patient's distress. And so through our assessment, our perception, thoughts, and feelings, nurses can usually identify what's happening, what is making the patient act and present those symptoms. And so basically, I feel that fits with the ED very well because you're coming in and, you're clenching your chest and you're going like this and you're pale and you're sweaty. I'm going to assess that as you might be having a heart attack. And so I need to move down that line to confirm that. So, and that was it. Any questions?
No.
Okay. All right. Thank you.